Good afternoon and a very warm welcome to everyone joining us today. My name is Kumota and I'm your moderator for today's International Scientific Webinar session. This series of webinars is proudly organized by the Malaysian Association of Science Officers, dedicated to promoting excellence, knowledge sharing and collaboration within the scientific community across Malaysia. Thank you for joining us and let's begin. Antimicrobial resistance, also known as AMR, presents a multifaceted challenge demanding coordinated efforts across human health, animal health, and the environment, a One Health approach. While the scale of the problem can seem overwhelming, there are countries demonstrating remarkable progress in bending the curve of AMR. Our session today will focus specifically on one such nation, the Netherlands, to understand their comprehensive strategies from surveillance and stewardship to innovation and policy. Prepare to gain actionable insights as we discuss antimicrobial resistance in view of the Netherlands, which is also the title of the webinar today. Just a reminder that we will have a dedicated Q&A session towards the end of the presentation, so please submit your questions into the chat and we will do our best to address them. The chat feature is also available for general comments or discussions among yourselves. Now it is my absolute pleasure to introduce our distinguished speaker, Dr. Jan Nouwen. Dr. Nouwen is an Associate Professor of Infectious Diseases and the Coordinator of Global Health Education at Erasmus MC, University Medical Center Rotterdam in the Netherlands. Dr. Nouwen's journey in medicine began in 1989, leading him to specialize in internal medicine and infectious diseases. His impactful research, for which he received the prestigious GSK 1C AAC Award, has delved into critical areas such as the Staphylococcus aureus and MRSA eradication. Beyond his clinical and research prowess, Dr. Nouwen is a visionary in medical education. He has been the trainer for the infectious diseases subspecialty at Erasmus MC since 2007 and notably developed the minor global health program, sending over 120 students to more than 60 international partners annually. His passion for curriculum innovation, including e-learning and serious gaming, has profoundly shaped medical training. Currently, Dr. Nouwen is spearheading the development of a global network for research education and academic training, fostering international collaborations with medical schools worldwide. His dedication to building a better together global research infrastructure truly embodies a commitment to global health equity. Please join me in extending a warm welcome to Dr. Jan Nouwen. Dr. Nouwen, the screen is now yours.
Okay, thank you so much. You can hear me?
Yes, we can, Doctor.
Yeah, okay. So thank you very much for the kind introduction and the invitation to give this lecture today. Good afternoon to you all. It's 9 a.m. here, so still morning, early. And I will start by trying to share my screen. Okay. So I hope everyone can see my first slide. So I was asked to talk about antimicrobial resistance and specifically the viewpoint or the perspective from the country I'm from the Netherlands. And what I will do, I will give an introduction about AMR. I think many of you know what AMR is and what the problem is, but there have been some more recent publications to really show the extent of this global threat, I think we should say. And then in the second part, I would like to dive into what is needed to combat AMR, and specifically what we try to do in the Netherlands for this specific problem. So I said, I'm Jan Nouwen. I'm an internist-infectious disease specialist. I work at Erasmus Medical Center. That's in the picture you see in this slide. And as you can probably see from the picture as well, the hospital building in front looks quite new, and it is quite new. It's we finished building and started using it in 2018, which is about somewhat more than 7 years ago. And I will come back to the reason for building this hospital as it is, and the advantages and perhaps also disadvantages of such a new hospital. So, I mean, we very often see these kind of slides like superbugs, a global attack. But if you see the reports on antimicrobial resistance, then probably this picture is familiar to you. This was a Lancet Working Party publication a couple of years ago already, where they predicted that in 2050, 10 million people per year would die from resistant infections and from infections from resistant bacteria or fungi or viruses. And what you can also see in the picture from that report is that the number of deaths, that about 9 million of these 10 million would be in either Africa or in Asia, and that's the global north, so to say. Europe and North America would only be impacted in a limited way if you compare that with the other continents. And in the same report, they said, okay, there's 10 million deaths to be expected from AMR in 2050, which will be more than from cancer or from other infectious diseases or other causes worldwide. So really stating that this was going to be a very impactful development. And so I think antimicrobial resistance is a real global problem, and that one of the things it does is that it urges us as healthcare professionals, but also governmental bodies and society, because in introduction it was already said, it's not only human, it's not only the hospitals, it's also agriculture, it's also the veterinary sector, it's really the environment, really a One Health approach which is needed, but that we really need to take action, and that's AMR as it develops is really threatening healthcare by an increasing range of resistant microorganisms developing. And that if we don't do anything, it will really have an impact on things we take for granted at the moment, like chemotherapy, surgeries, elective surgeries, because if everyone is going to be dying from resistant microorganisms after surgery or cancer chemotherapy, then of course these things we do on a regular basis, on a daily basis, will become impossible to continue to do. So it will hurt regular care very much if we don't take action. And then of course there's an economic issue that treating patients with infections with resistant microorganisms is more costly. So healthcare costs will go up. Patients will stay in the hospital for a longer time than before. So also that incurs costs, additional tests, and of course the use of more newer, probably expensive drugs. Now there has been a lot of debate on this first Lancet issue. People said, this is infectious disease doctors crying out loud that their problem is the biggest one, and this is an overestimation of the problem. And that's of course what very often happens, like also with climate change, that people start crying that it is not true and that you're just overestimating and asking attention. mainly to keep the status quo and not having to do anything subsequently. So about 3 years, 2.5 years ago, there was this other Lancet publication, which was looking at the global burden of bacterial antimicrobial resistance in 2019. So this was really a follow-up of the first report. And in that Lancet article, they clearly show that at that moment already, in 2019, nearly 5 million people were dying, and that their deaths were associated with bacterial AMR. And note, they're not looking at TB, they're not looking at viral infections or HIV. They're just looking at only bacterial AMR. So this is before COVID. When COVID came around, of course, the use of antimicrobials went up enormously, with a lot of patients ending up at the ICU. So probably the problem after COVID is much worse than from this publication in 2019. But this is real-time data. So, I mean, you could say the first report was an exaggeration, but if you look at these figures, then you really realize that that was certainly not the case, and perhaps the case is worse than was predicted before by the first report. And what is a repeating issue in AMR is that low-income countries and middle-income countries are hurt more than the high-income countries, if it concerns antimicrobial resistance, if it concerns the amount of people dying from AMR, or if it's costs incurred by AMR. And this is from the same report. Now, last year there was this huge Lancet publication again on the global burden of bacterial antimicrobial resistance. And so they looked at data from 1990 until 21, and then forecasted that to 2050 again. And this is from the infographic from that series, where they show that at that moment, really already 7.7 million deaths are associated with bacterial infections, and that 5 million from this 7.7 is associated with antimicrobial resistance, and 1.2 million are caused by bacterial pathogens resistant to all antibiotics available to treat. And what you also see is that the prediction is from 2005 to 2035, there will be a 100% increase in antimicrobial resistance expected. So clearly showing that there is a trend towards increasing AMR on a global scale. And also from this report, they clearly show that young people, old people, severely ill people in hospitals, and also those in resource-constrained settings are the ones who will be the most vulnerable, and that again, countries in low-income countries and low and middle-income countries will be the countries which will be hardest hit by the AMR pandemic. And then, of course, so this is a publication from 1.5 years ago by Mark Mendelson and colleagues. Mark Mendelson is an infectious disease specialist in Cape Town in South Africa. And in this publication, they described what they call the gray divide. So the inequity there is between the north and the rich north and the poor south. And not only in diagnostics and treatment resources, but also in inequities in priorities. So what the global north thinks is important to combat AMR, and what is needed in the global south to combat AMR, and that these inequities threaten the global mitigation of antimicrobial resistance. So there's certainly something we need to do. And then lastly, so this is a publication which was also published about 1 year ago, and this is more on the economic impact of antimicrobial resistance in humans. And this is what's called from the Eco AMR series, funded by WHO, World Bank, and other organizations, and mainly a report funded by the UK government through their Fleming Fund. And also they clearly show the economic impact of AMR and the future predictions of the economic impact by AMR until 2050. And you can clearly see the total cost will triple if we don't do anything to combat AMR. And the other thing is, what you can see is that in low income and lower middle income countries, the effect will be more pronounced than in high income countries. If you look at the increase from the economic cost incurred by AMR. And what you also see is, if you look at countries where costs will be or are highest, then you see that in China and in the United States, they are the big drivers of AMR. If you look at costs incurred on their healthcare system and economic costs as well. And of course, if you look at other countries, smaller countries, and I found the Netherlands here. I didn't find Malaysia so quickly in this picture, but you see that the contribution of other countries is much smaller, of course, depending on their GDP and their population size. But you can see that there are some big countries which are really driving this incurred cost, economic cost by AMR. And again, if you look at low, middle, high income countries, you will see that if you look at percentage of hospital admissions involved an antibiotic-resistant infection, that the highest amount is in low income countries and the lowest amount is in high income countries. Again, confirming what we saw already, looking just at antimicrobial infections, resistant infections, and the same for these economic spin-offs of these infections. The report ends by with a very positive note. So it's not only negative. They say that if you won't do anything, cost will rise enormously. So healthcare cost will rise from 66 billion to 160 billion in 2050 if we don't do anything. And if resistance rate increased at the rate of the bottom 15%, and thereby meaning the countries where they have the most AMR and increase of AMR for the last decades, you will see that healthcare costs will, due to AMR, will increase even up to 325 billion. And the global economy would be 1.7 trillion smaller in 2050, which has a real economic impact on a global scale. But they also say that if we provide high quality treatments, if we provide high quality infection prevention, if we develop new innovative antibiotics and vaccines, then healthcare costs could be cheaper even. And the economy could be nearly 1 trillion bigger as well. So the conclusion of this report is, yes, we have a huge problem. And we need to do something about it, but we have the means on a global scale as a global community to act and to invest. And this is, I think, one of the nicest slides, pictures of that report. That if you look at the yellow-orange bar here, so this is the cost of the interventions we need, which is about 200 million. And if you look at the benefit, macroeconomically, GDP-based reductions in healthcare costs, the benefit is 28 times the cost of developing these innovations and interventions. So to end on a positive note, if we act, we have the means to act, and if we do it in the right way, it's good for patients, it's good for people, but it's also good for our economy in the future. But we should act now. And again, looks a little bit like the whole climate change discussion. Now, as said, of course, we know what the causes of antibiotic resistance are. it's mainly in human health, overprescription of antibiotics by doctors. It's about poor infection control in hospitals and clinics, and related to that, lack of hygiene and poor sanitation, lack of new antibiotics being developed. Now, this is something which has changed enormously for the last couple of years. I mean, I've given another presentation about newer antibiotics. If you look at how many new combinations of older antibiotics and beta-lactam inhibitors there are, but also if you see how many new classes of antibiotics are being developed, then this is, for the coming years, probably not the main issue. There's a lot of development and a lot of investment now also from pharmaceutical industry. So this is becoming less and less of a problem in my opinion. Of course, there's a lot of overuse of antibiotics in livestock and fish farming. So that is something like overprescribing antibiotics in the human sector. So we need to do something about that. And then patients not finishing their treatment, you can have a whole discussion about that, because more and more data become available that many of the infections we treat for like 5 days or 7 days or 10 days or 14 days, because it's in the guidelines, can really be treated much and much shorter. So patients not finishing the treatment use short course antibiotics, and perhaps that's better than if they would finish that treatment. But that's a discussion for another presentation, I guess. You could do other things. I'm not sure if you're familiar with this one. So this doctor says that doctors prescribe too much, write too much prescription. So he's writing you a sonnet. And also patients try to be very clever about taking their medication. But of course, this is not the innovations we are waiting for. So then turning to the Netherlands. So this is Erasmus in the back. He's the name giver of our university, and one of his quotes is, "Prevention is better than cure." And of course, that's always the case. If you can prevent someone getting sick, then that's cheaper and better for the individual than if you have to treat a certain disease that has developed. And I think that we know really what we should do. I mean, from all kinds of research, we know what we do, and it all starts with infection prevention and control. Now, I showed you in the beginning a picture of our hospital, which is about 7 years old now. And this hospital was developed specifically from the viewpoint of comfort for patients, but very much also from the viewpoint of infection control and prevention. Meaning that all patients have a single room. So it's a single room hospital, like a VIP or very VIP hospital in other countries. So every patient has his or own room, has his or her own shower, sink, toilets, etc. And all the like all the equipment is individually, and there's even a couch bench which you can fold out into a bed where relatives can stay if needed, if a patient is very sick or if a patient is disoriented. So it's really like a hotel room. And of course, if you want to practice infection prevention and control, this is something making infection prevention and control much easier than if you have to work on an ICU like this. And I mean, also on our ICU, all ICUs are developed such that patients are in their own isolated room. So there's not a big ICU with 5, 6, 10 beds and healthcare personnel running through each other. It's all dedicated single rooms also on our ICUs. So, of course, we all know the 5 moments of hand hygiene. And I think there's a task for healthcare professionals, for nurses, for doctors and others to comply with these steps and rules for infection prevention and control to comply with infectious disease guideline. But it's also up to hospital management to provide the healthcare professionals with the proper equipment and the proper soap and hand hygiene to be able to practice infection prevention and control in a proper way. I mean, if the soap is 10 meters away from the patient, the doctor and the nurse, when they're very busy, do not have the time, literally, to go there, wash their hands, see the patient, come back and wash their hands again. I mean, it must be in the direct environment of the patient you take care for. Otherwise, it won't work. So it's, on the one hand, training people to comply and give them insights in why it's so important, but also in developing your hospital such that everyone can easily access hand alcohol and soap, etc., to comply with these guidelines. And for that, you really need an infection prevention team which checks on a regular basis how things are going and how compliance with all these guidelines they have is going. And I think that's also a repetitive story. It's all about implementation and enforcement of these guidelines. Now, in the Netherlands, we have a very specific body, which is the Inspectorate of Healthcare under the Ministry of Health. And what they will do is they will come and visit hospitals unannounced, and they will check how hospitals are complying with, in this case, infection prevention guidelines. They will just go to the wards and check if doctors and nurses are practicing hand hygiene, washing their hands, or using hand alcohol, complying with guidelines for infection prevention, etc. And they will make a report for that. So in the situation of my hospital, Erasmus Medical Center, about 10 years ago, they came to rate the hospital, and they produced a report that we were not doing a very good job. And they gave us a yellow card. And they said, you have to really improve, because at the moment it's not good. Doctors and nurses are not complying with hand hygiene properly. There's not a proper adhesion to prevention guidelines. So you really, really need to improve. And they said, we will come back. We will not tell you when, but we will come back. And if things are not in order, then the only thing we can do is close the hospital. So everyone in the hospital at first, of course, is shocked by the findings, but then work as regular takes over and not much changes. And then they came back a second time, and they had the same findings. And then they said, okay, this is a second yellow card, so this is red. So essentially, we're going to close down Erasmus Medical Center. Now, of course, we're the biggest university medical center in the Netherlands, taking care for complex care patients. So shutting down the hospital is really something you will not easily do. But the message to the board of directors was very clear. And the board of directors said, this is not something we can continue with. So what they did is they really enforced through all the department heads that people should and would comply with hand hygiene and infection prevention guidelines. And they also said that if an individual is not complying with our infection prevention guidelines, he or she will get a yellow card. And if, despite this warning, he or she is still not complying, then you get a second yellow card and you have a red card and you are fired. So there was a very strict implementation of that. The Inspector of Healthcare came back and said, wow, you really improved. So you can continue working, but you should improve further. And the funny thing now is that young healthcare professionals, young nurses in training, young medical doctors in training, they don't know any better now. I mean, they see their nurses, they see doctors complying with infection prevention guidelines, dressing up rightly, not wearing rings, not wearing watches during clinical care, etc., complying with the 5 moments of hand hygiene. So young people in training, they have these role models who act and who do proper infection prevention guidelines. So they don't know any better than to comply with these infection prevention guidelines. And I think that's very, very, very important to do, and really that implementation should be done properly, but that also enforcement should be done properly to be able to have proper infection prevention and control in your hospital. And then again, if you work in a hospital like ours, it makes life easy to do because you have only to take care of one patient in a room, and you have all the facilities for infection prevention, hand hygiene, hand alcohol, etc., at your disposal. So I think that another point to make is that designing your hospital really makes a huge impact. And of course, the Netherlands is a rich country. We put a lot of money in health and healthcare, and we're able financially to build these types of hospitals. But I think that also in middle income countries and lower income countries, we should think about how to properly build hospitals to prevent the spread of resistant microbes within hospitals. And that having patients in a ward with 8 to 10 or 12 beds in the current era with a lot of resistant gram-negatives spreading is not the way to prevent antimicrobial resistance. So it's something we should consider, that also developing hospitals is really, really important in the future to combat antimicrobial resistance. Then, of course, there's diagnostics, because if you do not have a proper microbiology laboratory, if you do not have a proper clinical microbiology service, you don't know what's going on. You don't know if there's resistant microorganisms in patients or not, if resistant microorganisms are spreading, if there's an outbreak. So you should have your diagnostics on par too. And then again, it makes it easy if you have a full-fledged laboratory like this one, or if you have to do with a laboratory like this in low-income countries. And again, and that's also where Mark Mendelsohn's article publication about the Great Divide is about, that if we need to take care for low-income countries and lower middle-income countries, we really need to invest in these types of diagnostics and training of people to be able to perform these diagnostics. And then I think one of the main things to take into account is antimicrobial stewardship. So I showed you in the early picture that overprescribing of antibiotics by doctors is one of the most important problems in antimicrobial resistance. So this is a picture from already 10 years ago, but it still holds. And it shows you the consumption of antibacterials in primary care in Europe. And it shows you how many antimicrobials are being used in Greece, and then all the other European Union countries up to, on the right, the Netherlands. And what this picture depicts is that doctors in Greece prescribe the most antibiotics in the European Union, and doctors in the Netherlands prescribe the least antibiotics in the European Union. So we are very hesitant in prescribing antibiotics, specifically in primary care, but also in the hospital, if you compare the Dutch situation with other countries in the European Union. And that has an effect, because this is methicillin-resistant MRSA in Europe. This is an ECDC plot showing the proportion of MRSA in blood cultures with Staph aureus. And what you see is that in the Netherlands, less than 1% of Staph aureus in blood cultures is MRSA. You also see that in Iceland and in Denmark, in Finland, Sweden, and Norway, and in Lithuania, it's about 1 to less than 5%. So they are in the same category as the Netherlands. And it is not, it is for a reason, because these countries have very strict guidelines on MRSA. In the Netherlands, we have what we call search and destroy policy. The other Scandinavian countries have a similar policy, meaning that if you are a healthcare worker and you're carrying MRSA, you're not allowed in hospital. You're not allowed to perform clinical care. So you have to go for treatment to try to eradicate MRSA from you before you can resume clinical duties. Also, if patients are repatriated from other countries because they've been on holidays in Europe and they have an accident and they end up in the hospital, the moment they come back to the Netherlands in a hospital, they are put in strict isolation, in MRSA isolation. MRSA cultures are taken, and if they're MRSA negative, then isolation precautions are lifted. If they're positive, they have to stay in strict isolation. And so there's several categories we have where we say, okay, these patients are at high risk of carrying MRSA, so we swab them to see if they are carrying MRSA or not. To search for MRSA, and then also if they are positive to try to eradicate, to destroy MRSA, and in the meantime use strict isolation precautions when they are admitted to the hospitals or when they are seen in our outpatient clinics. But you see, like in Greece, up to 50% of blood cultures with Staph aureus is MRSA. In Romania, it's even more than 50%. So showing that being prudent with your antibiotics, being restricted in prescribing antibiotics to patients really has a spin-off into how much antimicrobial resistance, in this case MRSA, but I can show you similar pictures of gram-negatives there are in your country. And there's been a lot of debate that if you are surrounded by these countries, that you are on an island and you're never gonna be able to sustain that policy and these low percentages. But up to now we have. So it's you do what you need to do, and it pays off in this case for MRSA, but also, as I can show you, for gram-negative, resistant gram-negatives. One other thing in the Netherlands we do is we have our yearly surveillance. So we have 2 reports published every year, which is called NETMAP. And NETMAP is consumption of antimicrobial agents and resistance among medically important bacteria in the Netherlands in humans. So in human healthcare, primary healthcare, hospitals, tertiary healthcare. And MARAN is monitoring antimicrobial resistance and antimicrobial uses in animals. Because of the One Health issue and because of human doctors in the Netherlands prescribing the least antibiotics, and up till 10, 15 years ago, our veterinarian colleagues who prescribed the most antibiotics in Europe. So we had a lot of spillover from antimicrobial resistance from the veterinary sector into the human sector. Now already for many years, there's this joint publication, and the publication is all about which antibiotics are used in primary care, in secondary level hospitals, in tertiary care hospitals, in different wards, so a normal ward versus an ICU. Which microorganisms do we see there mostly causing infections? Do we see an increase in development of resistance within these microorganisms within our healthcare system? And how do hospitals compare? So this is just the same slide likely as this one. This is for Europe, but this is within the Netherlands, and this is just an anonymous list of hospitals where you can see that there is a big difference between hospitals and prescription of antimicrobials as well. There's hospitals where there's a lot of antibiotics prescribed, and there's hospitals where there's much less antibiotics prescribed to patients. Now, of course, one bias in this is that probably lower level hospitals prescribe less antibiotics because they have less complex cases, and that, like in tertiary university medical centers like mine, we use more antibiotics because we have more complex cases and take over patients with complicated infectious diseases from other level hospitals. But it shows you a way to look at hospitals, and hospitals can look individually. So am I here, or am I here, or am I here? And what should I do, and what can I do to limit the prescription of antibiotics and to limit the spread of antimicrobial resistance within my hospital. And then, of course, the question is, does it pay off? If you do strict antimicrobial stewardship, does it have an effect on a patient level? So this is already a publication from the Netherlands, already 9 years old, in Lancet Infectious Diseases. The group headed by Jan Prins from Amsterdam. And they clearly show that if you look in literature, that mortality is lower if you have strict antimicrobial stewardship programs in your hospital. Because if you combine all the publications that have been there, the odds is on the left of 1 is less than 1. So there is an effect on mortality, and the effect is mostly if you look at Staph aureus bacteremias and doing bedside consultations for Staph aureus bacteremias, that if a dedicated specialized doctor, either a microbiologist or an infectious disease specialist, is taking care of a patient with Staph aureus bacteremia and giving advice on diagnostics and treatments, that mortality is lower. So yes, antimicrobial stewardship is not only effective in trying to limit prescription of antibiotics and thereby trying to limit antimicrobial resistance, but it also has an effect on the quality of patient care, and it also limits mortality in patients with certain types of infections. So what you need for that is really an A team. I'm not sure if you're familiar. I'm already old, so I know this from my youth. As the guys who you ask to come in to solve your problem. But I think, like the infection prevention team, you really need a dedicated antimicrobial stewardship team to check what antibiotics are prescribed in your hospital and to steer it in the right direction. And again, also here, it's all about implementation and enforcement of antimicrobial stewardship guidelines. So coming back to my own hospital, Erasmus Medical Center. So we have 2 ways of doing that. One is that we have a very intense infectious disease service line. So we do a lot of clinical consultations for infectious diseases within our hospitals on every department. So that could be questions from doctors taking care of patients. So could you help us, advise us on which antibiotic to give or which diagnostics to do? It's also about positive blood cultures, which we communicate with the treating physician. So your patient has a positive blood culture. So what is the problem? And then discuss diagnostics and treatment options with them. But at the same time, every day we have a reporting of which antibiotics are used in the hospital. And there's an algorithm which tells us which patients have reserve antibiotics, like the carbapenems, meropenem, for instance. If we are in clinical consultation and advised to use carbapenems or not. And if not, if we have not been consulted about a patient who is put on carbapenems by a doctor in the hospital, we contact that doctor to ask, why do you prescribe carbapenems, and should we not switch to another antibiotic? Is this really needed or not? So trying to enforce our antimicrobial stewardship guidelines within the hospital. And the same could be for antibiotics which are given intravenously for a long time. Then the algorithm will say this patient is getting antibiotics intravenously. Could this patient not switch to oral antibiotics? And then also we call with the treating physician to discuss if the patient cannot switch from IV to oral antibiotics, which in most cases is really an option. And then, of course, the doctor is very thankful because the patient might go home with oral antibiotics instead of having to be admitted with IV antibiotics as well. So that's a way we try to do it. And of course, with all the AI, which is in development now, these algorithms can be better developed and can become more specific. But it's really, on the one hand, a lot of work from the clinical consultation of infectious diseases side, but it pays off to do that. So that's one way. The other way is that on a monthly basis, there's a reporting about antimicrobial use per department. And this is publicly available. So department heads will see how much antibiotics and from which categories on their department have been prescribed. And it's also compared with other departments. So they will see if their antimicrobial prescriptions were appropriate or inappropriate, if carbapenems were prescribed a lot or not. And they can compare themselves with other departments. And it's a little bit of naming, blaming, and shaming. And no department heads wants to be on the top of the list of the department with the most inappropriate antibiotics, because the department head will become very anxious to try to change that and tries to discuss with his staff and perhaps also with us how to change antimicrobial prescription at his or her department. So that's another way of trying to enforce our antimicrobial stewardship guidelines. And then the third one, again, is this Inspectorate of Healthcare. They will check the hospitals. They will ask for reports of the hospitals about antimicrobial stewardship, about antimicrobial prescriptions, about appropriate and inappropriate antimicrobial use. And then if you do not do well, again, they will give you a warning that you really have to improve. And that's for, again, then the board of directors to act upon these warnings by the inspectorate. So this, for the infection prevention control and the antimicrobial stewardship guidelines, I think it's a very specific Dutch situation how we are organized in trying to implementing and enforcing all these guidelines. The point really is that the doctor on the ward taking care for his or her patients is not so autonomous anymore if you look at infection prevention and if you look at antimicrobial prescription, because someone is looking over your shoulder all the time if you're prescribing prudently or not, if your antimicrobial prescription is appropriate or inappropriate. So doctors lose some of their autonomy and have to hand it over to infectious disease doctors and infection prevention nurses, etc., for that part of their work. For some, that feels really uncomfortable because they are the doctor, they know all. I think in Malaysia, I know from Indonesia very well, but I think in Malaysia as well, some doctors think they are God. We also have those type of doctors in the Netherlands, of course, and they think they know everything about anything. So they also know best how to treat a patient with an infection with antibiotics. Well, they don't know, really. Because with all the antimicrobial resistance, with all the mechanisms of resistance to antibiotics in specifically gram-negative bacteria, this development is so quick and so intense that even for me as an infectious disease specialist, it's difficult to keep track of all the mechanisms which lead to antimicrobial resistance, specifically in gram-negative bacteria. And you need help from the experts. And the experts in this case are clinical microbiologists who have a job in understanding and finding out what kind of antimicrobial resistant mechanisms there are and which antibiotic you can use still or which antibiotic you cannot use anymore. So that's really a dedicated job. And doctors don't know anything, everything. So there's one professor in microbiology in the Netherlands, Mark Bonte, he's from Utrecht. And a couple of years ago, he said that if you want to, if you have cancer or if you have leukemia, you go to an oncologist, you go to the hematologist to get treatment with chemotherapy. because they know how to treat you for your malignancy, and they know best. They know about the combinations of chemotherapy. So if you leave cancer treatment to the oncologist and the hematologist, please leave antibiotic treatment, infectious diseases treatment to the clinical microbiologist or the infectious disease specialist, because it has become so specific, so complicated, that as a normal doctor, you cannot know anything. So please leave some of your autonomy to another specialist to be able to treat your patients in the most adequate way. But that's the situation in the Netherlands. It's just one way, one example, but I think it's an example which can be transferred, hopefully also to other settings in the future. And as I said in the introduction, we really need to act on the antimicrobial resistance problem very quickly. So to conclude, this is what we know. Overprescribing of antibiotics is really an issue, and we should tackle that. We should really have proper antimicrobial stewardship guidelines in place, and doctors need to give up some of their autonomy to be able to come up with the best treatment for infectious diseases for patients. Poor infection control and lack of hygiene, I showed you, this is something which hospital management should provide to healthcare personnel, but also think about how to develop a hospital for the future to prevent the spread of antimicrobial resistant microorganisms within hospitals. Of course, overuse of antibiotics is for the veterinary colleagues, but they also, with the One Health approach, which is mostly covered now for this antimicrobial resistant problem, are very active on that as well. Lack of new antibiotics, as I said, there is really a pipeline coming with new antibiotics, so that's very positive. And patients not finishing their treatment, perhaps we should be happy that patients do not always finish the treatment if you look at antimicrobial resistance. And then coming back to the Lancet article from 22 about the reporting in 2019, where they concluded that yes, AMR is a leading cause of death around the world. There's the highest burden in low resource settings, and we really need to understand the burden of AMR. So there needs to be surveillance in countries about the cause of infections and the prevalence of AMR. We really need to have proper infection prevention and control programs. We really need, all countries need to have access to essential antibiotics and to the newer antibiotics and the newer vaccines being developed in the pipeline, and the West should not all take them for themselves first, like they did with the COVID vaccines. And we really need to expand microbiology laboratory capacity for data collection and for diagnostics to understand how the problem of antimicrobial resistance in specific hospitals and in countries is. So we need good infection prevention, we need good microbiological diagnostics, we need good stewardship programs also, and specifically so for the new antibiotics coming in, and we need a good infectious disease consultation service. Because we know that all these items really work. And antibiotics don't work for COVID, so don't use antibiotics for viral infections. Use your antibiotics prudently. And thank you for your attention.
Thank you, Dr. Nouwen, for the insightful presentation today. Your expertise on AMR in the Netherlands has provided us with invaluable perspective today. We now have some time for questions, about 5 minutes. On that note, dear participants, we'll now transition into our Q&A session. If you haven't already, please submit your questions using the Q&A feature or the chat box, and we'll address as many as we can here. So we already have one question from Madam Vidu here. Good evening, Prof. What is the reason behind the high number of AMR in African countries, although economically they may not afford high-end antibiotics?
Yeah, so that's that's a good question. The problem really is that there's in one of the publications there's 3 slides of the global situation on AMR and death rates from AMR. And if you look at 1990, then there's a lot of people dying from antimicrobial resistant microorganisms in Africa, and then in 20 years later it's less, and then predicted for 2050 it increases again. Probably so. AMR is a global problem. So, and people travel. AMR is spreading in all countries. And if in countries in sub-Saharan Africa with limited resources in hospitals like diagnostics, but also of antibiotics, then really if a microorganism becomes resistant to, for instance, the 2 most used antibiotics in a country, without having access to newer antibiotics, then people will die from these infections. And many of these deaths could be averted if these countries would have access to newer antibiotics and to treat patients with these newer antibiotics. But at the same time, you would need, again, proper diagnostics also to test, because very often there's no way to test which microorganism is causing the disease. There's no way to test if it's resistant or not, and you're just limited to using a limited number of antibiotics for treatment of infectious diseases. And if patients have a resistant microorganism, then you don't have the proper antibiotics, then people will die.
Thank you for that detailed response, Dr. Nouwen. I think there is another, it's not a question, but a comment, I think, from a user named Sun. The concept of isolation room bed is good, but financially wise, our country may not be able to support it. I think this might be true for a lot of lower and middle income countries.
That's what I said also. I mean, we are in a rich country, and there was a long debate about what type of hospital we would like to have. So finally, they ended up with this single room hospital. But yes, if you have to rebuild all your hospitals in also middle and lower income countries, there's a lot of money involved. On the other hand, if you look at the economic report which was published recently, investment in combating AMR really pays off in the future. So yes, for the short term it costs more money, but for the long run it will save you a lot of money. And I think that's also like a global effort, that the global community sees that this is something which is needed and puts money in rebuilding or building new hospitals which are better equipped to prevent the spread of antimicrobial resistance within hospitals. Yeah, but true, it's more expensive to build. And the other point is you have less capacity because you have less beds because of that also. So that's another point.
Thank you, Dr. Nouwen. There's another question from Madam Vidu here. How much does uncontrolled usage of antibiotics in poultry contribute to AMR in humans?
A lot. So in the Netherlands, we had a big problem of that, let's say 20 years ago. And we had in poultry spin-over of vancomycin-resistant enterococci, of quinolone-resistant gram-negatives, spilling over from the poultry sector into the human sector. And it has been shown also for other veterinarian sectors that antimicrobial use as a growth factor, because that's what they use it for, is really contributing to antimicrobial resistance in humans. So yeah, and that's also the reason why in the Netherlands they had this initiative to to really also in the veterinarian sector look at antimicrobial stewardship and to check for antimicrobial stewardship and enforcing that as well to prevent this spillover.
Thank you, Dr. Nouwen. I believe there are no more questions coming in, and our time is also running out. So with that, dear audience, I think we have reached to the end of this session. And as we conclude our session, I want to extend our sincere gratitude once again to our outstanding speaker, Associate Professor Dr. Jan Nouwen. Dr. Nouwen, a huge thank you for your outstanding presentation to us that has given us a very valuable insight and perspective on AMR and in the Netherlands. We truly appreciate you taking the time to share your knowledge with us today. And of course, a huge thank you to all of the attendees today, our engaged audience, for joining us. Your interest is what makes this discussion so vibrant and essential for scientific progress, particularly here in Malaysia. Before we sign off, for more information on the Malaysian Association of Science Officers' upcoming webinars, please visit our website or follow us on our social media platforms. On behalf of the Malaysian Association of Science Officers, thank you once again all for joining us today. We hope you found this webinar both informative and inspiring, and we look forward to fostering continued scientific dialogue and collaboration within our community. Please also do not forget to kindly fill the attendance and feedback form for your e-certification purpose. With that said, have a wonderful rest of your day. Thank you to Dr. Jan Nouwen, and goodbye
Thank you very
everyone
much.
for now. Thank you.
Okay. Bye-bye.